Hello there, and welcome to Roundtable. I'm your host, Adam Cooke. Joining me this week are 4 members of the Strait-Richmond Palliative Care Society. They're here to talk about the state of palliative care in our area at the present time, how things have changed for palliative care over the years, including during the last 2 pandemic years, and what's needed to be able to provide services to those who need palliative care the most. As well, we'll clear up a couple of myths about what palliative care really is. You're going to meet these 4 members of the Strait-Richmond Palliative Care Society in just a second, so we thought we'd let them introduce themselves. Here they are.
Hi, my name is Elaine Noseworthy. I live in Grantville, and I began as a hands-on volunteer in 1983. I am still with the Society and presently with the Grief and Bereavement Group.
Hi, I'm Sandra Davis. I joined the Society in 2018. I'm a relatively new member. I recently moved to Arichat.
Hi, my name is Odilon. After I retired more than 10 years ago, I joined the Palliative Care Society at the Strait-Richmond Hospital. Of course, this society is comprised of volunteers who donate their time to assist people who are dying, to help their families cope with the stress of losing a loved one.
Hi, I'm Margaret Herdman. I live in Pondville, and I joined about 10 years ago, but I had a little interim blip in the middle of my time with the group as I had had a few major surgeries. So I'm joining the Grief Bereavement Group in the future, and I look forward to working with people on the phones.
I'm very pleased to welcome all 4 of you, members of the Strait-Richmond Palliative Care Society, to this special edition of Telil's Roundtable program. We have a lot to cover as we look at what the Strait-Richmond Palliative Care Society is doing in the present time, but I'd like to begin by setting it up a little bit, and I want to shift things over to you, Elaine Noseworthy, if we could. Could you give us a bit of background on how the Society came together and what its purpose and mission statement is as we look at its work in 2022. Elaine, the floor is yours.
Thank you. The palliative care program at the Strait-Richmond Hospital began in 1981 with Anne King as part-time palliative care nurse, Everett Harris, social worker, and the first volunteer, Allison Keefe. The program was established to help meet the needs of terminally ill patients and their families. When Anne King moved away, Mary B. Euro was appointed part-time palliative care coordinator. At the time, she felt the only way to get funding from the government for palliative care support was if we formed a society. So in 1994, the Strait-Richmond Palliative Care Society was established with 6 volunteers who were visiting and providing support to patients and their families. Since then, the Society has worked diligently to help provide the best possible comfort measures for end-of-life patients and their families in the Strait-Richmond area. The Society at present has 24 members, including 1 member from the First Nations. Some of these volunteers are also in-hospital patient visitors and grief and bereavement volunteers. The palliative care program is not only for cancer patients. It is also available to patients with ALS and other end-of-life diseases. Early referrals are best to help patients receive pain and symptom management in order to have a better quality in their life. And referrals can come from either the patient, family, nursing home, or hospital. End of life does not mean the last weeks or so before a patient dies. Once the pain and symptoms are managed, they can live for a long time. The patients and their families are also informed about the hands-on volunteer program. And if the patients request a trained volunteer, then a referral is put into the palliative care coordinator, who introduces the volunteer to the patient. This program, unfortunately, is on hold at the moment because of COVID. Hopefully, it'll start again in the near future. When Mary B. Euro retired, Nancy Cameron filled the position of palliative care coordinator. After a few years of proposals and much lobbying, Nancy's position became full-time. When approached by nursing staff and concerns regarding families after the death of their loved ones, Nancy set up training for a grief bereavement program. She would make an initial call to the bereaved family member, and if they were interested in the grief program, she would match the patient with a trained volunteer. The volunteer makes 4 calls to the next of kin in a 1-year period, starting with a month after the death of a loved one. As with any volunteer programs at the hospital, confidentiality is the #1 priority. This program has resumed after a short shutdown because of COVID. When Nancy Cameron retired, Kyla McKeegan was appointed as palliative care coordinator. Later, a 0.5 position became available, and Leah LaRue and Kyla worked together as coordinators. These positions are now filled by Sarah Tenor and Kyla McKeegan. We are very grateful for the palliative care physicians from Antigonish who have been doing hospital and home visits in the community for a number of years. Presently, we have Dr. Philip Cooper, who comes down from Antigonish every Wednesday. And the palliative care team is an important factor in keeping palliative patients in hospital or at home. Because of the palliative care team presently, about 50% of palliative care patients in the Strait-Richmond area are able to stay at home. And that is amazing. Palliative care addresses the physical, psychological, social, and spiritual needs of patients. Now, the society was founded on certain principles, including promoting quality care of the terminally ill and their families, working with palliative care team at the Strait-Richmond Hospital to maximize resources for patients at end of life, supporting recruitment and training of palliative care volunteers, encouraging and financially supporting staff development and education, increasing public awareness by presenting to community groups such as local service clubs, seniors groups, retired teachers, CWLs, and closely working with nurses, occupational therapists, social workers, physiotherapists. The Strait-Richmond Palliative Care Society has its own entity, but it advocates for Nova Scotia Health. So the accomplishments, the first achievement was setting up and furnishing a palliative care family room at the hospital, supporting volunteers, society members, and healthcare professionals to attend annual national and provincial palliative care conferences, hosting educational in-services at Strait-Richmond Hospital with out-of-town guests, contributing to grief and bereavement sessions, working with the staff on semi-annual times of remembrance, this is very important, especially for families, just to be able to get together and have a service, a memory service. And most of the time there's also staff there, and it is healing for the staff as well as for the people who have lost loved ones. Hosting Caring Day and Appreciation Day for palliative care staff and volunteers, organizing team building days for staff, and also team breakfast for the palliative care team. Supporting weekly palliative care clinics at the hospital. A group of society volunteers met with nursing home staff on a monthly basis, and that's really great because we're including all the different areas for that also. Furnishing and redecorating 2 inpatient rooms at the Strait-Richmond Hospital. And now we are also looking at hopefully being able to purchase a cuddle bed for the hospital to help with families who, especially with families who have young children and children want to spend time with their loved ones who are dying, or even for couples. So that is presently on the table, and hopefully that will be done in the near future. Purchase equipment such as comfortable chairs for patients and family, special mattresses for patients in the hospital, we purchase items that can be loaned out to patients at home so that we can keep them at home. It's funded palliative care education for volunteers, hospital staff, physicians. And we also we're very fortunate to have Georgette Burke with us, and she put together a grief booklet, and she's one of our volunteers for bereavement And this booklet is also translated in French and Gaelic. And at the moment, we're trying to get it translated into Mi'kmaq. And these booklets are included in a package from Nova Scotia Health that was sent to families after a loved one has died. Staff Appreciation Days. The Society has held pizza days for all staff at the hospital and for long-term care homes in the Strait area, ice cream days, dropped off baskets of goodies to the hospital and long-term care homes on various occasions, especially during this really difficult time with COVID. It was appreciated, I think, even more that somebody was thinking of them and dropping things off. Nancy and some volunteers have put on education sessions for various community groups. And we've recently had a website, which is, we had a website, but it has just recently been launched, all fresh and new, thanks to Sandra in our group. The Society plays an important role in helping palliative care patients. It wants to assure that these patients who for numerous reasons may not be able to die at home have access to the best comfort measures in a hospital setting. Daisy Day in May is our way of educating the public about palliative care, and we thank all those who donate to palliative care. We are very grateful to all those who have donated and continue to do so in memory of their loved ones, to the municipality of Richmond, who has been very generous in donating over the past years, Peter Chafe, who so kindly donated flooring for 2 designated palliative care rooms at the hospital, to the Nest, who continues to donate, to the artists from the First Nations who donated amazing artwork. This will be hung in the hospital as soon as the renovations are all completed. It helps make our hospital a better place to be when needed. Over the many years that I've been an in-hospital palliative care volunteer, I've been honored and privileged to share in the final journey of someone who was dying. Since the Grief and Bereavement Group was formed, I have focused on reaching out to family members after the death of their loved ones. I have made many lifetime friends. I've always said, if I was having a down day, all I had to do is spend time volunteering for palliative care and I would just get very uplifted. I've gotten so much more out of volunteering than I could ever give. So the Society holds its meetings every second Friday of the month, and that is open to everybody. It's on Zoom currently, and anyone can join the Society if they so wish. The Society is always available to welcome new people and of course we do need some younger blood. We are hoping to reach out to younger people who would be interested. And the contact person for the Society is the chairperson, Derek Cameron, and he can be reached at 902-631-2470, which is on his information is on our website. And it can be for, if you wanted to be a grief bereavement volunteer, you would contact Derek and he would give the information to the people at NSHA who are the ones that have the program, the training program, and then you would just follow up with them.
Well, thank you, Elaine Noseworthy, for sharing some history and some detail on how exactly the Strait-Richmond Palliative Care Society works and what it's doing these days. I'd like to ask you a bit about some of the myths surrounding palliative care and whether it's simply a service for those who are dying or for the families that are dying. And I wonder if you can speak to that a little bit, Elaine.
Okay, well, the one thing with palliative care, once there has been a diagnosis, that's the time to get everything into place with palliative care. Getting a diagnosis of cancer or, end of life cancer or whatever, doesn't mean you're going to die tomorrow, as I mentioned before. People live for a long time. I can speak from experience because of one patient that I was doing volunteer work with, and they didn't think he'd survive two days. And 2 years later, I was still doing visits with him because his pain and management had been controlled. He was able to go home where he wanted to be. He was not eating properly in the hospital. He had kind of given up. But once he got home and was comfortable and had palliative care coming in to see him, he just blossomed. He was, like I say, 2 years before he actually died after the diagnosis. So, and sometimes I think what it is that if you're in a lot of pain, when you first get the diagnosis, you're still in pain. If pain and symptom management is not controlled, you're not going to be wanting to look forward to living a long life. But if pain and management is controlled, then you get your life back for however long you have. So it's really important to get that done right away. And I've seen it lots of times as it turned around.
We appreciate your personal perspective on that as well, too. And that's part of the reason that I've asked each of the four of you to join us for this specific roundtable discussion on the Palliative Care Society, is because you all have experiences with palliative care and seeing the ins and outs of it. And I'd like to begin the next part of our discussion with you, Margaret Herdman, if I could, because you bring a specific, unique perspective in terms of what you've been through for palliative care that helps to direct your work with the society. And I'm wondering if you can tell us about that now.
Well, my husband died about 23 years ago, almost 23 years ago now, in an area where there was not palliative care available in the home, but he wanted to stay home, so that's what we did. And we had some community support from friends and more distant family, but my children and I did all the care other than that. And he was in the hospital for a very short period of time, less than 8 hours before he died. If we had had palliative care at home, of course, he could have died at home, but we certainly were able to extend his life at home for quite a while. But what I can see from that experience, the value of having palliative care available in the home which we have here, is so different. And that's really the reason that and the fact that Nancy Cameron was fairly persuasive in showing how valuable it was an experience to become a member of the group. But that's really why I joined. And I have had a little bit of experience in the hospital, but not a lot before I wasn't able to do it. So I'm going to start with grief and bereavement very soon. And so it really is different, and it certainly was valuable to keep him at home. The sharing of what the family experience was. But it would have been wonderful to have had nurses and doctors coming in on a regular basis instead of desperately calling and seeking help. That's a tough one. So.
Well, we appreciate your sharing your experience with us, and we're glad to see that things are certainly not the way that they were for you with you and your husband, and glad to see the work that you're doing and your fellow society members are doing as well too in this regard. I want to shift over to you, Sandra Davis, because you have some thoughts about your experiences with palliative care and how it's helped direct your participation in the Palliative Care Society. So just wondering if you could share those with us now.
Yes, and I think the difference between Margaret's story and my own is that palliative care has changed a lot. The healthcare system has identified it as quite a strategic need and an important part of healthcare. And so when my brother was diagnosed, palliative care kicked in right away. And he had two teams. So the first one team was based out of Halifax, which was, of course, all the specialist doctors that he might need during his journey. The second palliative care team was right here in Richmond County. It was sorry, I'm going to get emotional.
That's all right.
It was absolutely stellar. The palliative care professional team kicked in right away. So we had Dr. Cooper, we had the palliative care nurse, we had community nursing, we had home care, we had equipment that was donated. So my brother's hospital bed came from the Red Cross. We had wheelchairs, walkers, commodes, whatever we needed. The nursing teams made sure we got the equipment as we needed and as his health declined. So the support we got was absolutely phenomenal. Home care would take over as he progressed. So initially they would help him with his showers. Then they were doing bed baths. We got lots of tips from the nursing team about caring for my brother. I think what's important for people to understand if you're caring for your loved one at home is, one, loved ones can provide the best care 24/7 because, as we know, nurses have multiple patients in hospitals. So the care we were able to give him was, as the nursing team said, phenomenal at that time. The second thing is that for family members, they're cherished moments, but so you go through a lot of laughter, you go through a lot of tears. Towards the end, it can be physically and emotionally exhausting. The supports we got from Nova Scotia Health really tried to give us as much as they could in terms of advice and support. Towards the end, of course, we were administering all of the his medications, including injections. So the nurses, for example, would come and preload syringes for us, and we had different feeds into his body. And we were able to hold his hand and be with him right until the very end. And of course, as we all know, during this time of COVID, if he would have been in hospital, he would have died alone. And we were so fortunate in that, and he was fortunate in that he was able to be with his sons and his daughter-in-law and his wife and me when the time came. And all I can say is we were absolutely amazed by the health care support we got from Nova Scotia Health and the entire community. It was outstanding and phenomenal. And it's a shame, Margaret, that you didn't have those same resources 23 years ago. So it's difficult, but if we had to do it again, we would do it in a heartbeat.
I know that wasn't easy for you to share, Sandra. I appreciate it.
It's still fresh.
Yes, we greatly appreciate you and Margaret as well being able to share these personal stories about people who have meant so much to you. I want to shift to Odilon Boudreau over in Arichat. And Odilon, I imagine a lot of what Margaret and Sandra is ringing true for you because you've been there in the palliative care unit with people who are making their end of life plans. You've heard their stories, you've held their hands, you've prayed with them. So can you tell me a little bit about how that has impacted you and why you're motivated not only to be involved at that level, but also at the society level because of all of this?
I'll tell you why I joined palliative care and what it is for me. My own emotional experiences with my mother, uncles, and cousins and other family members who died when I was in the room made me aware of the importance of support needed during these trying times. People need to die with dignity, and I underline dignity, and they need someone who cares and loves them to accompany them on the journey of dying. People live in denial, and they do not like to talk about death. Reality is that we are all going to die. All living things die. Different people react differently to the dying process. Dying, fear of the unknown. There are some who resist and do not accept death. They fight it to their last breath. There is nothing wrong with being afraid. These feelings are all okay. There are some who welcome death because of their older age, do not feel useful anymore, or because they are suffering. There are some who were brave in life, who are genuinely afraid, even terrified of dying. There are some who were not brave in life, and they are very peaceful and accepting of death. We need to meet people, dying people, where they are at, and to say to them that it is okay. You are going to be okay. We can help them cross over if they are a person of faith. If they are not a person of faith, we can accompany them in their final journey and make it a peaceful death. Hold their hand, listen to them, and be there for them and the family. Personally, I talk too much, and dying people have taught me to be a better listener. And that was a hard thing to do. When I first meet someone who is gravely ill or dying, they are strangers. I get to know who they are and who they were from the family. I learn about them from their loved ones. Did they like to play pranks? Did they have a good sense of humor? Were they grumpy? Who were they? Each had his own personality and life experiences. They lived important lives. When they are sick, they are not necessarily the same person, especially if they are on painkillers and sedated. Yet you get to know them as you sit with them, and with some you make special bonds. They are glad to see you when you visit them. One spouse and her daughter said to husband and dad when he was suffering and would not die, "Listen, Dad, listen to this Frenchman, this crazy Frenchman, and let go. It is okay for you to let go." The family appreciates what you do for them, and later when you meet them in the community after the patient has passed, they are excited to meet and greet you. It is a warm, rewarding experience for the caregiver. You know that you have done something for one human being and for his or her family. A good palliative care program needs space and money so that all patients can die with dignity. These are two importance that are important to assist in the delivery of palliative care moving forward. Square area space, and more money. There's always a need for money to buy equipment for the hospital. We need to get and equip rooms that are dedicated to and for palliative care patients. We depend on the generosity of you, the public, to provide funds necessary to buy the equipment. Larger hospitals have more rooms available and more money. Consequently, they have state-of-the-art facilities. In a small hospital, you need all of the rooms that are available. There are no extra spaces. When patients come in an emergency, they take over the beds so that you could not provide any quality long-term care in the facility to accommodate their patients and family. What to do? We need to lobby politicians and our governments to provide more spaces in our local hospitals so that we can have rooms dedicated to and just for palliative care. This would allow for cuddle beds and other equipment to be set up in these rooms so that couples could be together in the hospital while the other or the significant other is dying. Now, COVID-19 is a challenge. It is important that people get the vaccine so that families and volunteers can accompany their loved ones when they are dying. Too many older people are dying alone, or they are dying with people in the room who are wearing masks and other protective gear. We need to get people back into the rooms of patients. We have dehumanized the dying process. The best way to remedy this problem is to be unselfish and to get the vaccine so that we can have our lives return to some form of normalcy sooner. To those who would say, let them in the room without any PPE, personal protective equipment, when a family member is dying, I would say, we need to take care of our healthcare system, which is already stressed to the limit, and we do not need more sick people. In summary, palliative care allows people to die with dignity. Palliative care also assists people who want to die in a friendly, familiar environment at home. Palliative care workers and hospital staff make this practice easier and possible.
Hearing from you and hearing from Sandra about the difficulties involved in providing palliative care during the COVID-19 pandemic and how the system has adapted and adjusted. And I just wonder if anybody here wants to add any follow-up commentary to that about the challenges that the Palliative Care Society and those providing the palliative care have experienced over the past 2 years, but also any of the successes. Anybody want to jump in on that?
One thing we found, of course, during the COVID time was that when any of the home care or professional nursing teams came out, of course, they had to get into full PPE when they came into the home. While saying that, we did not see any compromise in the service we were given and supports, except, of course, the palliative care team, the personal visits went down from once a week to once every 2 weeks. So from that perspective, it was great. It was both a blessing and a curse. A curse in the sense that if immediate family wanted to come and visit from away, they needed to quarantine. So we were able to manage that. And it was a blessing in that the people who did come to visit were able to bring their jobs with them and do them here while they were working. So in that sense, they didn't have to worry about taking time off from work to come and be with my brother. So in that sense, I found that the healthcare, it just kept going. There was no decrease in the quality or the availability of services to us. It was phenomenal. I can't say enough about them. It was so amazing.
I was just going to mention the grief and bereavement part too. During COVID, of course, everything came to a stop, and it was really, but then when it started up again and contacting the families, it was just unbelievable what they had been through when their loved ones were dying in the hospital. Some of them, like, it was only one person that was allowed there with them, so a lot of the family members couldn't be there. It was, and what was the worst, I think, is that the person died without being able to see their, like, say, grandchildren or their spouses. Sometimes they, some of them didn't even get to do that. So in speaking with families after the fact, the bereavement part of the program was just so needed. We do have it going again now, which I'm very, very happy about. But the stories that you get from these people, it's heartbreaking. The impact that COVID has made on people who were dying and the interruption in the service.
I wanted to bring up a point, Odilon, that you brought up during your remarks as well, too. The idea of provincial funding for palliative care in this area, but also the necessity of fundraising that the society does in terms of local residents and local activities. And I just wonder if any of you would like to speak to the tightrope walk that you folks have to do as a society, that you are dependent on provincial funds, but also very dependent on local fundraising as well, too. Would anybody like to pick up that point?
Well, we don't receive provincial funding. The society has received some wonderful support from the municipality and really from individuals. And the important thing is that with our society, all of us are volunteers, so there is no one earning money. So any monies that we receive from the community go 100% to helping with purchasing equipment or providing additional services. We're trying to identify gaps in service areas, simple things for people going through this time, like mowing the lawn or being able to pick up groceries for them. So we're looking at those kinds of things as we move forward. And it's just been amazing, the level of support that we get from individuals and other community groups to support what we try to do and how we try to help the professionals in the field.
We are heading into the home stretch of our conversation, and I did want to ask where we go from here as a society. And I know a big part of that is strategic planning for the society and for the various services it provides. And I'd just like to put this out to any or all of you as to what are the next steps in the strategic planning process.
We're just wrapping up. We are developing a 3-year strategic plan. We're just fine-tuning it and developing from that an action plan. The areas, of course, we are a strong advocacy group, so we continue to lobby for palliative and bereavement care in the local communities. Another area for us is financially trying to fill those gaps that Nova Scotia Health is having trouble filling. We also have a promotion and public relations aspect to our work where, again, we're trying to teach people what palliative care is, what services are available, and always looking for volunteers who might be interested in helping out in any way. We had a group of people who sewed pillowcases for us last year for people who were staying, at home. We have school kids who create cards for people who are in hospital and may not have a lot of family support. And our other area of focus, of course, is keeping the society going, making sure we have some succession planning, and we'll be looking to the communities for people who are interested in volunteering and giving us a helping hand. Always appreciated.
I just wanted to wind down by asking if there is anybody else that would like to add anything just before we wrap up. And I see Sandra, you wanted to jump in?
Well, we'll do a little bit of promotion. We do have a website, as Elaine had mentioned at the beginning, a brand new refreshed website. So if anyone is interested and wants more information, they can go to srpalliativecaresociety.com. And we also have a Facebook page, and you can access the Facebook page from our website as well.
Adam, I just want to say thank you so much for your interest in doing this for palliative care, so that we can get our message across to everyone as to the how important palliative care is, and just to let people know what we are doing. And I think it was just wonderful that you were able to do that for us. Thank you.
Well, we appreciate the cooperation for all of you, and Tallil Community Television is very happy to support the Strait-Richmond Palliative Care Society in all of its activities. Marg or Odilon, any of you would like to add anything just before we wind things down?
I would just like to say thank you again. It's something that we all need to know about. So sharing, that's a great way to share it with the community. So
Thank you very much. Last word to you, sir, Odilon.
Yeah, same thing. I'd say a big thank you, Adam. And I think people need to realize how well organized and tremendous work that's being done. And I don't want to start naming names, but the ones that jump in my mind, done an awful lot of work are Elaine, of course, Nancy, Eric, but they are very well organized, and it's a very good society. And it's nice to see something locally that's doing so well. I'm impressed there with the organization.
We're all very impressed with all that you individually and your society as a group has done, not just right now, but through the years, and we're all very grateful for it. And I'm grateful to all of you for working with me on this. So thank you for joining me today on Tallil Roundtable.
Thank you.
Thank you.
And there you have it. That wraps up this week's edition of Tallil's Roundtable. A big thank you to our guests from the Strait-Richmond Palliative Care Society, Odilon Boudreau and Sandra Davis of Arichat, Margaret Herdman of Pondville, and Elaine Noseworthy of Grantville. Just a reminder that you can find out more about the Society by visiting their website, srpalliativecaresociety.com, and you can also find them on social media. Check out the Facebook group Strait-Richmond Palliative Care Society. And just a reminder that we are working on a number of episodes for Roundtable that will deal specifically with seniors issues, as we did this week. We're very grateful for the support of the Seniors Take Action Coalition and the Dr. Kingston Memorial Health Project in helping us put these episodes together, including the one you just saw. If you have any ideas or suggestions for future episodes of Roundtable that deal with seniors issues or anything else, please feel free to contact me personally or contact Tallil Community Television in Arichat with your thoughts and suggestions. That's it for now. I'm Adam Cooke. Thank you once again for tuning into this special palliative care edition of Roundtable.